Let's start today's program. But before we start, I will recapitulate what we learned yesterday. So you have some ideas, you remember some things, other things I will remind you. Yesterday's first session was hip preservation. Common lessons were two. One is avascular head does not always need to be sacrificed, and increasing the blood supply and aligning the biomechanics revascularizes most heads. I repeat, increasing the vascularity and realigning the axis of the hip revascularizes most of the avascular heads, leaving the patient with his natural hip, which will last him probably his lifetime. So the three different ideologies and strategies, more or less working towards the same goal, were described yesterday. Dr. N.K. Magu gave a wonderful talk on hip preservation, and carry-home messages were two. Do not sacrifice the head unless the patient is physiologically old and can afford a revision if it comes to be needed. Anybody below 60 who is healthy, irrespective of how high subcapital the fracture is, it can be salvaged by valgus osteotomy. Second lesson he taught us was a fixed angle condylar blade plate is the most stable implant which removes the lowest amount of bone to fix such osteotomies. So that is a forgotten art which has to be revived. I think these implants are not even available in large quantities with dealers. You ask for a condylar blade plate and he'll scratch his head and say, what? Locking proximal femoral plate? No. This plate costs hardly 700 rupees, 800 rupees, with all four screws less than 1000 rupees for the plate, and gives wonderful results. Next came Dr. Muhammad Yunus, who told us that even hips beyond salvage can give the patient a functional limb equal in length and pain-free walking, provided both the mechanical and anatomical axes are restored, pelvic support is given, and the shortening is lengthened. Ilizarov in femur and Ilizarov hip osteotomy, IHO as we call it, is not a beginner's procedure. However, Dr. Yunus demonstrated with these cases that for those who want to take up this subspecialty, this is one of the least developed specialties in the country and offers a phenomenal scope of growth. Then came the wonderful talk by Dr. Anup Mukherjee, who taught about how to medically revascularize an avascular head to increase his blood supply and obviate the need of a total hip replacement. That was a really wonderful talk, and his main theory was blood supply to the head of the femur is not constant in all people. So there are anterior foveolar vessels, anterior retinacular vessels, posterior retinacular vessels, and foveolar vessels. 1/3 of the hips are anatomically divergent, in which the predominant blood supply is by the posterior retinacular vessels. And in these cases, whenever the retinacular vessels get inflamed because of synovitis, blood supply is strangled and the head becomes avascular. The mainstay of his method was low-dose DMRDs in a specific cocktail or formula which he has evolved over 30 years. The most important aspect of Mukherjee regime is use of methotrexate, 2.5 milligrams alternate days, Monday, Wednesday and Friday, and neutralizing it with folic acid, 5 milligram Tuesday, Thursday and Saturday, and giving Sunday a rest. Vitamin D on Sunday, vitamin A every day, easily digestible protein, these sort of supplementations are added. In addition, he adds blood thinners and extremely low dose steroids. The combination looks complex. The story looks a little implausible or unbelievable despite him showing such X-rays and MRIs. But I can assure you that after we learned the method from him over the last 2 years, close to 100 orthopedic surgeons are using this method in their practice with spectacular results. Even with me, I have 3 patients who were advised urgent hip replacement, all 3 on Mukherjee's regime, 3 years down the line, and they have not gone in for hip replacement. Next was my talk on preservation, which was proximal fibular osteotomy, which is a subject still being explored and studied, and we need more data to tell us whether it really works. But my carry-home message was, in specific selected cases with precise indications, PFO delays knee replacement for a minimum of 3 years and a maximum of 15 years. Dr. Arvind Divakar Jain spoke about the magic bullet of phenylbutazone for ankylosing spondylosis. We have 1 or 2 boxes on the registration desk there. We don't have extra for giving you because whichever doctor had ordered, we had ordered for them. It's just 300 rupees for 500 tablets. Take a photograph of the box. You will find the company's name. Take it and give it to your local medical shop wala and tell him that you're going to use so many tablets a month or a year and insist on him to buy it for you. Afternoon session was new age era in reductions and plaster applications and discussed the commonest problem in children, that of supracondylar fracture. We heard 2 masters, Dr. Arvind Divakar Jain and Dr. Ghanshyam Narayan Khare, both speak about supracondylar fractures. Dr. Divakar presented his classification of supracondylar fracture, in which I have contributed a little, and then described and displayed his gravity method, which produces consistent results in all cases and does not require either a C-arm, general anesthesia, assistant or pinning. Dr. Ghanshyam Narayan Khare clearly espoused that except for extreme flexion, forearm immobilized in pronation locks the distal fragment, if accurately reduced, prevents slippage and consequently avoids gun stock deformity. We had demonstrations of local infiltration and featherweight plaster application on live patients yesterday. This was the pre-lunch session. So, preservation, restoration, conservation. Second part was devoted exclusively to Elizarov, but as we have conducted many Elizarov workshops and run through the standard Elizarov methodologies, 2 new methodologies were taught to you yesterday. One was Elizarov in distal radial fractures with 1.5 rings, 3 or 4 wires, with the magic of ligamentotachys. And after that, we learnt an unusual solution to a common problem of calcaneal fractures by the use of a stack frame or a bar frame. So, Bowler angle restoration frame and Kirpak subtalar frames are both wonderful innovations not given in book. We had a nice opportunity to interact with the faculty and try our hands on silicon models, which went on late till evening, and then of course we had a banquet. We are a little more crowded than we had expected, and the hotel is undergoing some major rush hour because of 2 movie shootings and 3 weddings, and they are short staffed also, so service had a lot to lack. However, the quality of academics made up for the services, and I have not had any complaints so far about the hotel. I am only having appreciation about the content of the course. Today, the program is divided in 2 modules. The morning module talks about things of interest to orthopedic surgeons, which shapes the way an orthopedic surgeon lives. The only talk that has been missed in this session is Dr. John Ebenezer's talk. Unfortunately, his connecting flight got missed and he's stuck in Germany. So he should be reaching India only late tonight. So he missed his flight. He conveys his apologies and promises that the next conference he will come and give a lecture. So, Dr. Mukherjee's missed lecture of yesterday, that is medical management to augment fracture healing, which will be a sensational paper, along with an orthopedic surgeon's overview of rheumatic conditions and their management, is clubbed into a longer talk of 45 minutes. This is the pre-lunch session. Post-lunch session, you will have a spectacular show by Dr. Satish Chandra Gore and Amjad Hamodi, who will be talking about the various gates, distal blocks, non-surgical management of discs, stitchless discectomies and the like, and I'm sure you'll enjoy them all. Let us start the morning session with the first talk by Dr. Rupesh Kumar. He had originally submitted this to one of the national conferences, but due to politics it was not accepted. He sent me the paper and I said, well, this is a paper for rural orthopedics. He said, no, it has not been accepted. I said, next time we have a conference, this paper is going to be there. And so here it is. This discusses the dilemma of a younger surgeon who has not been fortunate enough to be admitted into MS orthopedics, who has just completed his D-ortho. After D-ortho, how much pressures he is under to add some more qualifications after his name. Does adding those additional letters make him a better orthopedic surgeon? Does it make him a more successful orthopedic surgeon? What he should look for in life at that stage when he has just had his D-orth, full stop. And to give examples, we have Dr. PNVSV Prasad, who never bothered to add up any more degrees after he had his D-orth. He dedicated himself fully to orthopedics, learning what he learned. And today he runs a hospital where he sees an OP of 400 patients a day and has 4 assistants, all of them MS orthopedics. So that really doesn't mean that you need an MS or an MCH to succeed in life. All you need is a passion and dedication to orthopedics. I have a great pleasure in calling Dr. Rupesh to come and share with us his experiences.